Hi, welcome to Health IQ. I'm Dr. Alan Siegel. Tonight we have a special guest, Dr. Marshal Peris. He's with the CareMount Medical Group in Westchester County. He's a spine orthopedic surgeon. Welcome, Dr. Peris.
Thank you very much.
So, Dr. Peris, you have a unique specialty besides being a well-known spine surgeon. You specialize in something called sacroiliac condition, sacroiliac dysfunction,
Yeah.
and not that many orthopedic surgeons that I'm aware of really focus on this part of the anatomical orthopedic system. So tell us a little bit about the SI joint, where it is, and what types of injuries and conditions can occur with that.
No problem. So the sacroiliac joint is the junction between your tailbone or your sacrum and your pelvis. It's in the back. If you're looking at someone from the back, it's in their buttock. But sacroiliac joint dysfunction, when it's symptomatic, can mimic lots of things, including hip problems, arthritis in the back, disc problems in the back, even muscle strains. It can even mimic sciatica. So you have to keep the sacroiliac joint in your differential diagnosis when you're seeing a patient with back pain or sciatic pain, and always know that that's one of the possibilities.
So anatomically, things are somewhat close, and some of the pain patterns can mimic each other. So it is like you said, a differential diagnosis from a spine. So being a spine surgeon, it would be a natural, sort of example to look at the SI joint if you're having or unexplained pain that it can't be found elsewhere on imaging or diagnosis.
Correct. And even in training, many years ago, we learned that the sacroiliac joint was one of the possible diagnoses, but there really wasn't anything aggressive to fix the problem until just recently. So yes, back then we had physical therapy and medications and injections, but really the treatment stopped at that point. And if those things failed, the patient had to live in pain.
Now, are there certain specific diagnosis or diagnostic tests that you can do, like an MRI or an X-ray, that will actually show an SI problem versus a low back problem, like our patients are used to hearing about herniated discs or facet or problems, sometimes they'll hear, or arthritis in the low back. How do you diagnose this definitively, if there is a definitive way?
So there's certainly a lot of overlap, as you mentioned, and I call it what we call a diagnosis of exclusion. So we rule out the other stuff, plus you add in some physical exam findings, location of the patient's pain. You can even send them for what's called the diagnostic injection, meaning if you inject local anesthetic and or steroid into the sacroiliac joint and it relieves their pain for a good period of time, then you've almost proven that that's where the pain's coming from. So yes, we do imaging, and that imaging really is focused on the spine itself, because that's the one thing we want to prove it isn't.
Gotcha. So you're trying to exclude the obvious and then move on to the less obvious. Right. Now the SI joint, from my recollection, a ton of ligaments, very tight joint. It's not like a loose joint where there's a lot of mobility per se. So it's not. While it has some mobility, it's not a hypermobile joint in the terms of what people think of joint mobility of an elbow or a finger or something of that nature. So the mechanics are a little bit different. So what types of diagnosis would you say are like most prevalent? Like, is it a strain? Is it arthritic? Is there like cartilage in there that becomes degenerative? What would people be looking for?
It's really all the above.
Okay.
So the joint, if I may, barely moves. So it kind of rotates like this, back and forth. And the motion occurs when you're changing position. So really getting up from a seated position is when that joint moves the most.
And someone might experience pain at that point.
Correct.
So that might be one of the things that a doctor would be thinking about. Okay.
Yeah, so the questions I ask are, does it hurt when you get up from sitting? In some patients, it certainly hurts to weight bear on that side, or even lay on that side in bed.
Oh.
But the joint itself is very big, and cartilage on the inside. It is constrained by a lot of ligaments, and it does not move much, as you said. It's very tight. Arthritis is one of the diagnoses. Trauma, so car accident patient.
Sure.
Very commonly, they'll have their foot on the brake or the gas, and that shock can shift the sacroiliac joint and cause trauma there. Another unknown diagnosis or unknown problem that causes sacroiliac dysfunction is pregnancy.
Okay.
So when a woman is pregnant and the baby drops into the pelvis, all the hormones allow the pelvic ligaments to loosen up, to allow the baby to drop into the pelvis. And then after the baby's born, everything tightens back up again, but it doesn't always fall back into the same location that it was to begin with. And that can be a very painful problem, where you'll hear a young woman who's in her 20s and 30s tell you that she's had pain since right after she gave birth.
So what are some of the conservative approaches? I know we're going to talk about a specialty procedure that you do as a surgeon, but what do you recommend for patients once that diagnosis has been made? Let's just say it's early onset arthrosis. I mean, I know when you look at x-ray of a knee or even a spine, picking up like mild, moderate, or advanced arthrosis is easy. Is it more difficult in an SI joint to determine the level and how severe it is, or?
It is. You have to put together a lot of information. So most importantly, their patient will tell you where the pain is. But there's definitely overlap with the hip and the lower back in terms of sciatica. There are some physical exam findings you can put the patient through that really pinpoint that this is where the pain's coming from.
Yeah, because the joint line is very definitive from an anatomical perspective, and there's so much soft tissue around that. So you have conditions, piriformis syndrome, even gluteal trigger points. There's so many variables, like I said, sciatica, depending on where the sciatica is being caused or what's causing the sciatica. So you really have to do a very careful, thoughtful analysis. And I think the patient input, from a, if it's a sports injury, if you have a strain of that ligamentous area, that also could be a problem as well. So,
correct.
Now, if someone has advanced arthritis, procedural-wise, what are some of their options that you would do as a surgeon?
So just to get back to your question in terms of imaging, very rarely do I see on an MRI SI joint problem. Certainly on a CAT scan I can see arthritis. You can see joint space narrowing on an X-ray or a CAT scan, but more often than not, the imaging doesn't really tell me much. Now, in terms of, I forgot what the question was, sorry.
No. So just trying to figure out like what procedures you would do if you had different diagnostic, like arthritic, if it was mild or moderate. Would you recommend, therapy first, injections? What other types of procedures would you do before doing an advanced procedure?
Oh yeah, absolutely. So conservative management is the mainstay of treating this. And a lot of people get better without anything further than medication, activity modification, physical therapy, and an exercise regimen change, core strengthening. Some people will get to the point where that all fails, and those are the patients that may see a physiatrist or a pain management doctor for an injection or 2 or 3 into the sacroiliac joint. And if it really works well, that's the treatment.
Right. If they start to see diminished pain, diminished symptoms. Now, activity-wise, like, you might think like a martial arts type of person or gymnastics person or someone who's throwing a lot of load through like their hips and pelvis continuously. Do you find that those patients are more subjected or like more active, or there's no real rhyme or reason as to the type of patient? Like we're all living more sedentary lifestyles. Is that a negative for the SI joint? I can't imagine it wouldn't be good for the SI joint, but how do we know like who might be more susceptible in your experience?
Yeah, so in my experience, the patients I see a lot of are car accident victims.
Okay, so trauma, so big trauma. Okay.
Patients who've had previous spine surgery.
And let me interrupt. So the pelvic belt in a spine issue, does that cause some kind of excessive, stress right through the pelvis that might cause that because they have the seat belt on?
The seat belt definitely contributes to that trauma. Why that occurs.
Because it's right across your sacroiliac line, essentially.
Sure.
So that would make sense. Even though they're preventing them from, God forbid, going through the windshield, it is causing other issues, but hopefully things that can be resolved with some.
And it's a well-known thing that there are seatbelt injuries,
which
are well worth it in the whole life-saving.
Of course. All right, so beyond those traumas, any other types of like repetitive stress athletes or marathoners, runners, things of that nature?
I wouldn't say any specific athlete or type of athletic would be a cause of this. So I would say trauma, previous spine surgery, inflammatory arthritis patients, so patients that have an underlying diagnosis of rheumatoid arthritis or lupus or Crohn's disease or ulcerative colitis, they are prone to having sacroiliac joint dysfunction.
So systemic arthritis throughout the body can affect a lot of different joints, including the SI joint. So it's another joint that you'd have to be concerned about, especially if that's their primary source of pain.
Correct.
Okay. So let's just say you have a patient that has tried everything. They've done conservative care, physical therapy, they've had some injections, and they just can't seem to alleviate themselves from the pain, and they're on some, maybe some, NSAIDs or whatever. What is this procedure that you have been known to be specialized in terms of like an SI implant or a fusion?
Yeah, so sacroiliac fusion has been around for a long, long time because...
But nobody hears about it.
Right. But really the old days of sacroiliac fusion were big incisions and mainly used in bad trauma patients. Now we have a way to minimally invasively treat this problem through a very small incision, and the whole goal of the procedure is to prevent the movement. So if we can prevent the sacroiliac joint from moving back and forth, we get rid of the pain. And the procedure itself takes about 45 minutes to do. We do it under general anesthesia, just for pain control purposes. Patients go home the same day. They have a restricted weight-bearing routine that we do for the first 3 to 6 weeks. And then I allow patients to return to full activity by 6 weeks as tolerated.
So the procedure itself, what are you actually doing? Is there an implant? Is there a device? I'm sorry if you mentioned that, but and is it like a small screw or it's inserted? And is it typically like higher in the joint or lower in the joint? Because the SI joint, has a long line all the way down to the end of the sacrum there. So is it typically on a higher part of the joint?
So I actually have a model.
Oh, okay. That's helpful.
So this is looking at the sacroiliac joint from the back. We're basically showing half the pelvis and the tailbone here.
Okay.
The other part of the pelvis obviously is not in the picture, but the model itself has the 3 implants in it to show how they're situated.
Oh, okay.
So they're small, triangular in shape. I joke that they look like railroad spikes.
So they come from like this ilium, which is really like your pelvic bone, I guess, right? And then goes laterally into this sacrum.
Into the sacrum. So they're put in one at a time. And the whole
like what I use in my deck, it looks like some lag screws.
they're like, except that they're not screws. So the whole idea is for your body's anatomy to grow into the implant.
Okay.
So the implants themselves are very grit blasted on the outside, if you can imagine.
So bone
very rough.
Right.
They're lattice material, so
bone can kind of grow in
and around it.
Okay.
And the hole that I make in the bone to put it in is smaller than the implant, so it's what we call a press fit.
Okay.
So the implant goes in, and as it goes in, it's expanding the bone, and the bone itself is locked in place almost right away.
Okay. So it doesn't look like that will move after you, so that's a good thing, right?
Correct.
That's what you're trying to prevent, because it's the excess of motion. Now, are there any cases where there's actually a ligament that needs to be repaired if in a significant trauma, or like are those ligaments are so strong that they never really rupture or break? Because and there's probably so many of them, right? So
there are, and there's a lot of innervation nerve-wise in the area, but by preventing the movement of the sacroiliac joint, whatever damage has been done to the ligaments around that joint doesn't matter anymore, because they're no longer required to hold the joint in place. Because
of the surgery.
Correct.
Okay. Well, that makes pretty good sense, actually. Now, after you've done a procedure like that, is there any follow-up, or is it that the body actually does the fusion itself, naturally occurring fusion? There's no like bone stimulators needed or anything to help with that bone growth?
Correct.
Okay.
And certainly there are patients that we wonder, did it heal, did it not heal? And I'll do a CAT scan down the line and see what things look like, but that's pretty rare. So usually by the time patients are 6 weeks out from the surgery, I'm allowing them to put full weight on that leg as much as they can tolerate, and most patients that get to that point, they've already been walking normally for a few weeks before I tell them they can walk normally because they feel so good.
Now, so that handles the SI joint component. Now, have you seen cases where sometimes you'll talk about fusion in patients where like other areas become hypermobile or try and compensate too much for the fused area, either above or below that same joint line, or possibly in this case maybe in the spine or in a proximal area? Could there be other issues, or because it's so isolated it typically is rare?
So that's a great question, and as I alluded to before, patients that have had previous spine surgery tend to have sacroiliac problems down the line, especially spinal fusions.
Okay.
So if we're fusing the lumbar spine to the sacrum, which is called L4 or L5-S1 fusion, we are moving stress from the spine elsewhere. So it's either going up the spine or into the sacroiliac joint. And those patients will feel good after their spine surgery for a number of years, and then they come back with very similar complaints. And we know it's not the spine because we already fixed that problem.
The spine's already fused.
Right.
Right.
So we look at their hip joint, and if the hip's okay, the sacroiliac joint is the obvious diagnosis.
Yeah, I mean, there's so much going on, like you said, between the lumbar spine and then into the sacral area, and sometimes you have transitional segments which are fused between the lumbar and the sacrum, and sometimes those are naturally occurring, sometimes they're over time, and just trying to figure out the diagnosis is really, really key. And I think as a spinal surgeon, it's really important to recognize that difference. And even non-surgical doctors, physical therapists, physiatrists, I think having that differential diagnosis is important, because it's easy to say, okay, it's the lumbar spine. Even if you get a MRI with a disc bulge or a slight herniation, well, it's easy because you see it, but it may not always be the case.
Correct, and that's the one thing that we have to be cognizant of as practitioners is, even if there's a problem on an MRI in the lumbar spine, it doesn't mean that that's the source of the pain.
Yeah.
And so you have to be very diligent about looking at the MRI, examining the patient, and seeing what is really the aggravator for the patient's pain.
Yeah. Now, in terms of unrelated to the whole pelvic and lumbar, obviously you're a spinal surgeon, so what types of advances are you seeing in just your field in terms of like non-operative procedures? We're starting to hear about, stem cells is a very broad, loose term right now, but
correct.
Regenerative medicine. How do we get cartilage to heal? How do we prevent degeneration of cartilage, whether it's in the low back, maybe in the SI joint, maybe in the hip joint? What are you seeing? What are you hearing out in the field?
So probably about 20 years ago, we started working on gene therapy, where you would inject into the disc itself, and the body would then regenerate disc material based on the stem cell gene injection. That hasn't come very far.
Okay.
And the truth is that
all good things take a long time, right?
Yeah, even in the big joints like knees and hips, they're continuously trying to figure out how do we get our bodies to regenerate cartilage, because the number of joint replacements being done and the number of spinal fusions being done, all because the body is breaking down, there has to be a way that we can turn the body's key and subtract some years, so to speak.
Absolutely, and I think patients need to understand that surely there's trauma we know causes arthritis. Well, people can't avoid trauma. There's genetics. They can't always avoid their genetics, right? So there's a lot of things, but then there are things like, obviously like smoking, poor diets, not taking care of yourself in other nutritional ways that we can do to prevent some of the acceleration of these arthritic conditions. And I think it's such a big thing, especially as a surgeon. I mean, would you say like, more than 60% of your diagnoses are some kind of arthritic in nature, if not higher?
If not higher.
If not higher. So that word, although we use it very loosely, it's a real, medical problem. It's a significant problem.
Right. Absolutely.
Yeah.
And I think, arthritis is, in Latin, is inflammation of the joint, but we use it very generically for what's causing pain. And in the spine, or in the sacroiliac joint, sacroiliac joint definitely arthritis, meaning cartilage wear. In the spine, the facet joints do have cartilage, and that can cause arthritis when that wears away. But to say someone has an arthritic disc, we say that because people understand that.
Right. Right.
But the truth is, it's not an arthritic disc; it's a degenerating disc.
Right.
They've lost the height of the disc. It's dehydrated. The ligaments aren't as stretched out as they used to be, and the muscles are responding to that, and that's the reason for the pain there.
And would you say there's anything of, like, if you had to say, like, there's one thing I'd recommend my patients to do to try and prevent these things? We are a sedentary society at this point, or we're becoming one for sure. We're by the desks all day, we're by the computers all day, our kids don't move as much as they used to. There's so many factors that concern me, as not only as a parent, but as a healthcare provider. What do we tell our patients, whether nutritionally, physiologically, like, what is their best defense of these things, or is there no defense?
So, no, I think there is a defense, for sure. I think nutrition is important in the sense of maintaining your weight.
Okay.
So
you say, like, weight and obesity has a significant effect on arthritis?
No question.
Okay.
No question.
All
I think, we've heard in the past, as kids, you are what you eat.
Right.
But truthfully, what you're putting into your body is not getting into your joints and not getting into your cartilage. But eating a healthy diet and keeping your weight down are very important. If you could take a weight measure and put it inside your spine, it measures between 3 and 6 times your body weight. So a 10 or 20 pound weight gain is 30 to 60 pounds more on your spine. It's a huge number.
That is a huge number. And I'm glad you put it that way, because I don't think anyone's ever quite explained it that way.
Yeah.
And if you actually could show that on some kind of weight scale, I think people would say, like, oh, well, that's not helping my back whatsoever.
Not at all. And people will tell me, I've gained
Right.
a few pounds and my back hurts, and that's the answer.
Yeah.
But if you asked if there's one thing, there's probably 2 things. Number one, exercise.
Okay.
Absolutely have to exercise. So I preach non-impact cardio, however you want to do it. Bike, elliptical, swim, walk,
Rowers.
row,
Yeah.
stair climb. Runners are runners. And
Right.
if you're a runner, run.
Right.
That's fine. Core strengthening. Absolutely. So whether you do it on your own with videos, or you're taking a yoga class, or you're doing Pilates, you have to strengthen your core. And stretching, flexibility, very important. And then the last thing I always preach, and you brought it up earlier, is smoking.
Right.
That
Okay.
is the number one thing that correlates with people with back pain.
With back pain
Yeah.
or arthritis
Yeah.
in general, but yeah. Okay.
Number one.
Right. Well, hopefully as a society, I think we are slowly educating people to move away from these tobacco, nicotine products, and hopefully that we'll continue to educate our younger folks to stay away. So now nutritionally, we spoke about a few things. You are what you eat. I'm sure you get the question all the time about supplements, omega vitamins,
Sure.
Fish oils, glucosamine. There's been so many things over the marketplace over the years. What are your recommendations, just overall, just generally good healthy diets? Or
Yeah, obviously good
have you seen anything work really well? I'm sure the clients would like to know that.
Yeah, I think everything's going to be anecdotal.
Yes.
There's no scientific research that says this works and that works, and they've
Right.
done a trial of thousands of patients. But what I anecdotally, chondroitin, glucosamine tend to work for people that have arthritis of their big joints, the hips and the knees. Doesn't really help people with back pain.
No. Okay.
And then, on the other hand, there are herbal anti-inflammatories. One of the ones that people tell me about is MSM,
Right.
arnica. So these are anecdotal. People,
Turmeric. You hear a lot about turmeric.
Sure. People tell me a lot of Europeans
Yes.
they come from another country and they're like, this is what we take,
Right.
and it works.
And it works.
So you have to believe them.
Right. And even if it helps, like you said, we're always about kind of controlling our patients, their pain and their lifestyle and their overall wellness. And if something were to reduce, someone's discomfort, a certain percentage, is that helpful? Well, sure. I think it could be helpful. And surely if it's not doing any harm, not causing the same issues that steroids may cause, or long-term, or NSAIDs may cause. I know people don't want excessive medications. Hopefully, try and live a more, holistic lifestyle, be pain-free without having to take, chronic Advils and stronger medications where needed. So,
Correct.
Yeah.
But I think when you're in pain, using an NSAID is a good idea.
Of course.
No question.
Right. Yeah, because you don't want to. Yeah, pain is pain, right?
Right.
Surely ice, heat, things of that nature can always be helpful, but you need to. It's only for temporary, palliative care. So, now anything just while we're finishing up here, in terms of the spine, any new things on the disc replacements? I know that
Sure.
people always hear about that versus a fusion versus disc replacement, and there's a lot of, as a spine surgeon, you even know that there's so many different ways that spinal surgeons will approach different conditions, different procedures. So in terms of fusion versus disc replacements and things of that nature.
Yeah, it's a good question. So in the lower back, we'll start with that. The disc replacement never panned out. They're still being done, but it never was superior to fusion in terms of patient outcomes. So disc replacement in the lower back has really fallen by the wayside, but where it's really taken off is in the neck. The cervical spine disc replacement is wonderful.
Okay.
Works great. It's a game changer.
It's interesting anatomically. I don't know if it's because there's a little bit smaller joints, a little bit smaller bones. I mean, is there an explanation for that, or?
That's it.
That's it. The weight bearing
stress.
procedure, the stress.
Yeah.
Okay. Well, we spoke about the stress of the joint and the weight specifically, so maybe that's part of it. But
Yeah. So in your neck, it's just the weight of your head sitting on it.
Yeah.
The companies that have come out with the newest disc replacements in the neck have really designed them to mimic what a disc does when it moves. And there are probably 2 on the market that are far and away better than everyone else. And they work beautifully, and very few need to be revised or reoperated on. It's just been very impressive.
That's quite the advance for sure. And that's, I wouldn't say it's minimally invasive, the neck, or is it close to, at this point, they're doing a small incision through the neck and then going and doing, okay, so that's pretty good.
Yeah, the cervical spine surgery is mainly minimally invasive with a small incision in the front of the neck. I'm sure you've seen people that have the little incision right there. But we do almost everything through a 3-centimeter incision right on the side of the neck.
All right, so you've seen a lot of great advancements even in your career. I think minimally invasive procedures are surely the way to go. As we discussed earlier, hopefully with some regenerative medicine, some new biologics, some new ways of getting our body to help heal itself a little bit better. Hopefully prevent, not that we'll never need surgeons, because we'll always need surgeons, but try and change the philosophy on when and how and types of procedures that we do. I think those outcomes are really what's important to the patient and to yourself as a surgeon. So I think that's really great. So I want to thank you for being on the show. I think us talking about the sacroiliac joint, we are bringing light to the general public about that particular condition and that particular problem. And I think people that maybe have had quote unquote back diagnoses, this is probably a good point, that have not gotten better yet, all right, maybe need to seek out someone like yourself to say, hey, maybe it's not my back.
Right.
Maybe someone just hasn't evaluated me properly, or maybe they just haven't thought about it being a sacroiliac problem. And maybe I need to see Dr. Peris to see if I do have a sacroiliac problem that has been undiagnosed. And that might be a good way to end the show. So
happy to
I wanted to thank you for being here, and I hope our audience learned a lot tonight. So thank you. Good evening. Welcome. Thanks for joining Health IQ. Bye-bye.